सदांशु भाई, आप पहले शुरू करो, एक लाइन बोल दो.
Good afternoon, everyone. So, today in a quiet session, we are going to talk about a very important topic that can rehabilitate a person, change his lifestyle, and that is low vision aids for the community at large. So, low vision aids, there are many types of low vision aids. We know optical, non-optical, digital, electronics. So there is vast development in this low vision aids available in the market now, and almost all patients with dim vision get some help from any type of this low vision aids. So this is a very important topic, but unfortunately there are very few people here. So I invite Dr. Sampan Samanta to talk on the low vision aids.
Respected Dr. Shatangshu Mathur, the convener of this session, Professor Karamjit Singh, our beloved organizing secretary of midterm conference, Dr. Garg, honorary secretary of AIOCMTC and Haryana state chapters. Here, AIOS, Dr. Vikas Gupta, our honorary secretary of AIOCMTC and Haryana state chapter. Here in this AIOS midterm conference, the AIOCMTC has allotted a slot of 75 minutes for any discussion. Unfortunately, we could not find out many an AIOCMTCian to participate in this meeting. And at the same time, we the AIOCMTCians have chosen a neglected chapter of ophthalmology as well as the part of eye care services for the neglected people who are just hankering for a very minimum vision to go on with their day-to-day activities. That is nothing other than low vision aids for the community at large. And at the very introduction, I like to discuss how to implement it through AIOCMTC activities. But fortunate enough, we have got the beautiful speaker, Professor Karamjit Singh, who is the head of the Department of Ophthalmology of Government Medical College, Amritsar, and who is going on with a beautiful low vision aid clinic in his medical college. And he will kind enough to give an elaborate description of his pattern of activities. Let me allow to start to give you a brief idea of low vision aids which will be necessary for the community at large and how we the AIOCMTCians are planning to go through this particular service. Now the common diagnosis in our low vision aid clinics are mainly related to retinal diseases, maybe congenital retinal diseases or some acquired, starting from retinitis pigmentosa, age-related macular degeneration to ROP and retinal detachment. So also whole globe problem like atrophic bulbi and other. Optic nerve problem mainly with glaucoma and corneal scars as well as the cortical blindness and so many others. If we just like to go through a clinical profile of patients attending a low vision clinic, we can jolly well see that 63% the major part of the patients have got retina problems. And the other parts, whole globe or maybe corneal or optic nerve or anything like that. But retinal disease shares the maximum. And here are the causes a bit elaborately described and which has been published at Andhra Pradesh eye disease study, where amblyopia is found amongst 27%, optic atrophy in 15%, glaucoma 12%, and retinal diseases 30%. So these are the major causes. And the other causes like congenital eye anomaly, enophthalmos, and corneal scars, they are of minor degree. To give effect to the United Nations Convention on the Right of Persons with Disabilities in 2006, 8 subcommittees had been formed, and one of those subcommittees deals with blindness and low vision. So also, there's a revision in the definition of blindness and low vision rights of persons with disabilities Act 2016. Ministries of Social Justice and Empowerment have also changed the term blindness. Blindness means a condition where a person has any of the following conditions: total absence of light or visual acuity less than 3/60 in the better eye after best possible correction, or limitation of the field of vision subtending an angle of less than 10 degree in the better eye. So this is blindness. And low vision means a condition where a person has any of the following conditions, where visual acuity not exceeding 6/18 in the better eye with best possible correction, or limitation of the field of vision subtending an angle of less than 40 degree up to 10 degree. With these guidelines, in the year 2001, we have made these categories of 5 types of low vision. But the feedback and problems with this classification, that many patients falling in between 40 and 75%. Many patients not fitting in the options. It was very difficult for the doctors and cannot depend on better eye only. Worse eye standards should also be accounted for. So these are all the details of the condition in the better eye with best corrected vision as well as the worst eye with best corrected vision, and presenting impairment, as percentage of impairment, as well as the disability category. And here you can jolly well see that a person with 100% disability has only hand movement or only light perception or no light perception, like this. So this disability matrix was formed by Government of India, which gives a clear-cut idea and very straightforward, very quick assessment of the status of low vision in that, or blindness in that particular person. You can see on the bottom on the right hand, the 100% means no PL in any of the eyes. So also in different degrees, this particular matrix is important. It is recommended to use Snellen's chart or equivalent for best possible correction of each eye separately. And best possible correction may be medical, surgical, like these things. What is the percentile disability in the best corrected visual acuity? Suppose in the right eye if it is 1/60, then in the left eye it is 6/60, then better eye vision should be encountered. Suppose here is one such example. You can see on the top it is shown as the left eye, and in the east side this is the right eye. And 60% means in the right eye he has got 1/60, but in the left eye he has got 6/60 best corrected vision. In that way we should proceed to assess the vision, as well as we will mark the patient with low vision. Now field criteria. Coming to the field criteria, visual field, if it is less than 40 degree up to 20 degree across around center of fixation, or hemianopia involving macula, that person will be marked as with low vision. A visual field less than 20 degree up to 10 degree across around center of fixation, he may also be taken into account. So also visual field less than 10 degree across around the center of fixation, he will be taken as a person with low vision. Now here is another matrix chart where we have shown the field of vision around center of fixation. In this way you can see the right eye, left eye, and our field of vision. And in that way, 100% blindness means when the field of vision both in right and left eye is less than 10 degree of fixation point. Now the person with a benchmark disability means a person with not less than 40% disability. So a person having for more than 40% disability can only be given a certificate of visual disability. If any patient has got some field loss or also some vision loss, the greatest impairment of either whether visual field or visual acuity will be used for certification of overall visual impairment. Now, this blindness, this loss of vision, this low vision may be temporary or may be permanent. So the certificate can be temporary if condition like worsen and need reassessment. But the patient especially can be used a temporary certificate when he has got cataract, corneal decompression or any congenital glaucoma, which may be improved after surgery. So there's a total difference of our line of thinking, line of decision, what has been taken in 2001 to give one disability certificate to 2018, where the medical authorities are always comprised of the ophthalmologist. Otherwise, in the past, anybody except an ophthalmologist can be given a certificate. But from 2018 onwards, an ophthalmologist is a must, along with the medical superintendent or CMO, civil surgeon or others. There should not be any age limitation of beneficiary for visual disability certificate. At any age, he can be declared as visually handicapped. The benefits of visually impaired is there as per our ADIP scheme, which has been revised in the year 2017 by Department of Social Justice and Empowerment. Now, vision is a multidimensional factors. It may be distant vision, near vision, color vision, depth vision or stereopsis, contrast sensitivity, ocular motility, ocular reflexes. That's why whenever we will certify a patient with low vision aid, we have to take into granted with the different components of vision, whether distant vision, near vision, color vision, field of vision, stereopsis, contrast sensitivity, ocular motility, ocular reflexes. Now, at the same time, we have to keep it in mind about the milestone of development of the eye as well as the vision. So here are the different milestones of the different foveal reflex up to a confusion, the corrective fusion, all come step by step. Now here I like to show you some abnormalities in the eyeball like microphthalmos, anophthalmos, cyclopia, coloboma, which can give rise to low vision. So also abnormalities of cornea, different types of abnormalities of cornea. So also abnormality of the sclera, blue sclerotic syndrome. So also different anterior chamber abnormalities, Degas anomaly, congenital glaucoma. Abnormality of the iris, iridia and others. Abnormality of the choroid and abnormality of the retina. The retinal problems counts the maximum 61% of low vision aid. Retinopathy of prematurity, retinal dysplasia, congenital retinal detachment, abnormal retinal vessels and other things. So also the optic nerve atrophy and others. Abnormality of the lens also takes a part. So also abnormality of eyelids, abnormality and monocular elevation disorder, orbit problems and albinism, oculocutaneous albinism are one of the major causes of low vision aid. So also ophthalmoplegia, maybe myasthenia and other can give rise to temporary low vision, congenital night blindness and others. Other problems like visual development delaying, visual impairment with mental retardation, cone dystrophy, dyslexia, refractive error, they can also give rise to low vision aid. And here are some manifestation of vision impairment and proposed solution of it in pediatric age group. Unable to fix, they have got nystagmus, abnormal ocular diversion, white reflex, so many things and others. That's why we have given them so many devices which will be discussed by Professor Kamalji in my next lecture. And we have to change the reading books with font size, bring the book close to the eye and others. They can give in spectacles as well as telescopic lens. The non-optical devices, they can be given with optical devices like these spectacles and others. And they are unable to see at distance, that's why they may be given optical device, telescope and outreach. Their problem may be glare, there may be photochromatic glaze, sunglass and other things. Problem with contrast, optical devices, non-optical, all can be given. So, case studies with low vision, we have seen that In case of aphakia, scleral fixation IOL are also doing very good for them. So also in corneal opacity cataract IOL and puroplasty. So also in case of severe dry eye with low vision, amniotic membrane graft can do good to them. Ear capsulotomy in case of posterior capsular opacity in postoperative period. But in case of macular dystrophy and others, intravitreal steroids, as well as in post-RP, blepharophimosis and others, other devices can be given. So now, to assess the problem, between the year 2009 to 2010, Sarva Shiksha Mission, Education Department in West Bengal took up a large-scale project of identifying the children with visual impairment and to help them through provision of low vision device and corrective strategies. Two organizations having the capacity of low vision service are given 10 districts each for this extensive work. And here in West Bengal, these 10 districts have been taken, and through Sarva Shiksha Abhiyan, in 7 steps, 2 days hospital-based orientation training was given, identification of the children with defective vision and the major eye problems were detected, detailed low vision assessment of the children has been done, diagnosis of eye diseases by ophthalmologists at subdivisional level was done, corrective surgeries at base level was done. Following that, we have provided them low vision aid and follow-up visit. In that way, in each and every low vision camp, 40 to 45 visually impaired children were examined in detail, and they have been given proper management procedure and proper devices has been given them. And these are the follow-up camps where they have been followed up, whether they are using the low vision devices properly or not, and they have been given proper advices to carry on with that. And this is the successful networking with the Education Department from 2009 to 2013 in West Bengal. So, take-home message from West Bengal experience that meticulous history taking, genetic counseling, prenatal diagnosis, good postnatal care, multidisciplinary approach, early detection of the low vision, and preparing the individual for education plan can give the best way for the management of community with low vision. And with this, I just like to give in a nutshell a few lines on how AIOCM is working for the last 24 years towards the detecting the people and to reach the unreached population with low vision. Here, if you just go through the goal of AIOCM, you can see the goal of AIOCM mainly to prepare ophthalmic generation next, PGT session, to make them oriented with community eye health work at rural services, with international assemblies as well as the different awards to motivate the people working for the community through annual conference and this journal and felicitation. AIOCM is working for academic improvement. But through its community eye health survey, whether in the school or in the community or at village level, AIOCM is trying to find out the people with low vision. And in this, our partners in journey is National Program for Control of Blindness, Lion Sight First program. And our mantra is very simple, that's of Swami Vivekananda, attain until you succeed. We have to find out and make them motivated to undergo treatment. We have to break the wall of the communication gap between the blind and the existing service facilities. We like to make them aware of the existing facilities of eye health care management in their vicinity so that they can avail them. For that, for the last 24 years, we are going in different parts of Indian subcontinent, from Aizawl to Ahmedabad, from Kashmir to Kanyakumari, where they are. And you can see here, this is near China border in Arunachal Pradesh. In the middle, you can see in Kashmir. You can see above, we are in Koraput, in Odisha. And above, we can see in Nagaland. We are there everywhere. And so also we are there. There we can see Andaman and Nicobar. We are there at Myanmar border in Tripura, Myanmar border in Tripura, in Uttar Pradesh. And there you can see in Imphal, in Manipur villages. and in the middle you can see in Mizoram. Everywhere AIOCM is working for the last 24 years. And the latest model of AIOCM Drishti Rath Yatra from 2014, with this particular type of a tableau, we used to go on in the villages and villages with the message of positive eye health care, and at the same time we are examining the patients. And we went to Anantnag in the trouble-stricken Anantnag, terrorist-stricken Anantnag with our Drishti Rath Yatra, and trained all these girl students about positive eye health care, as well as we have examined many patients in search of visual disability. Here you can see we went door to door, even in Kashmir, in the apple orchards and others. Door to door we examine the people in search of their visual loss, in search of blindness, and give them the treatment when they don't like to come to our camps and other places. In Punjab, we went to Pakistan border, up to Gurdaspur, in Dera Baba Nanak, and these places with our Drishti Rath Yatra, and we have given our eye health care talks, as well as examine the people with blindness. We had been to Amritsar district in Punjab in the year 2002 in different areas, and given our talk and other places to school students and others towards positive eye health care, and examine the patients door to door in search of their visual disability. We had been to Jalandhar district in Punjab in 2022 with our message, and examine the patients, as well as we giving public health talk and others towards positive eye health care. In this way, AIOCM is working towards the implementation of its goal for positive eye health care for the people in necessity, as well as to give service to the patients with low vision aids. Friends, please be kind to assemble at our 15th annual conference of Association of Community Ophthalmologists of India in Palampur on 31st October, 1st and 2nd November. Here the dates are not there. And at the same time, I've got an advanced invitation to each one of you to the City of Joy, Kolkata, in the year 2026, from 24th to 27th of September, on the occasion of the Silver Jubilee celebration of AIOCM, and where we have the plan to assemble at least a couple of ophthalmologists from each of the districts of Indian subcontinent, 1400 districts, where we can again reconfirm as well as revise our activities pattern. With these things, thank you very much. With these children with low vision aid who requires your attention, your service for a better lifestyle, for a better tomorrow. Thank you very much. Thank you. Dr. Indar Mohan Rustogi, the gem of Haryana and one of the captain of AIOCM in northern India, for his kind participation. So also I like to welcome all the delegates who have just joined in our session AIOCM, and I would like to request them to enroll in AIOCM and to join at AIOCM Palampur in our annual conference. Now, I'd like to request Professor Karamjit Singh, the head of the Department of Ophthalmology, Government Medical College, Amritsar, as well as a pioneer AIOCMian for many years, who was successful to organize the first AIOCM CME in Amritsar about 10 years back, and which was well attended, and the chairperson was nobody else than Professor Jaljit Singh, Padma Shri Professor Jaljit Singh. He was very much inspired, and I can never forget the beautiful dinner he has hosted to all the delegates. And Professor Karamjit Singh is working a lot on low vision aid through his own institute, and I would invite him to give his lecture on low vision aids for the community, which he has done through his own institute. Professor Karamjit, please to come.
Thank you, sir. Thank you very much for nice introduction. So basically, so it is your inspiration that we started low vision aid clinic in our government medical college Amritsar. So I remember your first visit in 2012, sir, 13 year back, when we organized first CME on community ophthalmology, where low vision aid was one of the topic. At that time, we started low vision aid clinic in our hospital. Now it is successfully running. So my talk is very simple after your talk, sir. So basically, it is what we are doing for the low vision aids in government sector. So as we all know that low vision is a visual disability that cannot be corrected by glasses or by conventional medical or surgical treatments. According to WHO, the definition is within the context of the clinical practice is if the visual acuity is less than 6 by 18 or it is 6 by 18 to 3 by 60 in the better eye. So accordingly, if the patient it falls in this visual acuity standard, we prescribe them various low vision aids. So in India, so Government of India is also doing a lot for implementation of various low vision aid programs. Even today only I attended one VC with the Ministry of Health where low vision aid along with other causes of blindness was one of the topic. So Government of India is also doing a lot for implementation of these low vision aid clinics. So low vision, it is a chronic health problem which affects the daily life of an individual, like driving, performing daily tasks, employment, and even it affects the mental health of any person, especially the children. So even our target group is when we are going to school checkups, school surveys, there our main aim is to identify the children who need low vision aids, and we prescribe them low vision aids, and if the child is not able to purchase those aids, we are giving free of cost to those children. So these are the various components of low vision. How we can start a low vision aid clinic. Most important is low vision assessment, which is very important, low vision assessment. So for that, basically it is not only the visual acuity which is required. So we have to check the peripheral vision of that child or the adult also, that person. So accordingly, we can say that this child or this person needs this type of low vision aids. So we have to check the low vision, whether what is the type of the low vision, which part of the field is involved in the low vision. As sir told that most of the causes of the most of the persons coming to low vision aid clinic, there the central vision is lost because of either because of the diseases in the macular region or because of the diseases which affects the central visual acuity. So low vision assessment is very important for then after that the assistive device trial. So there are different devices that we can prescribe to the, I will discuss later on, which we can prescribe to the low vision person with low vision. Then of course prescription of those devices. So this is broadly we classify low vision devices into these four categories. One are the optical devices. Optical devices are basically the magnifiers, optical devices. Then the non-optical devices. Non-optical devices are basically assistive devices. assistive devices. With the help of those devices, a person can do his or her daily day-to-day activity. Third are the electronic devices. These days, so many electronic devices are available. Even these days, smartphones are helpful in many low vision aid abnormalities. And also there are some novel devices which recently are in the market. The basic principle of all optical low vision devices is the magnification. As we are using higher magnifiers to magnify the lenses, to magnify the images, so mostly the optical devices are the magnifiers. These are the few optical devices which we routinely use in our low vision aid clinic. The most commonly used devices are the microscopes. Microscopes can be handheld microscopes, or those microscopes can be fitted on the table. And second are the telescopes. So telescopes are basically uniocular devices. Uniocular devices, with one eye the patient can see at some distance when there is a decrease of the visual acuity at some level. And third are the magnifiers. Magnifiers are basically, we use these magnifiers for assessment of the currency notes, like currency notes, reading newspaper, reading books, like that. Then the field expansion prisms. These field expansion prisms are very much helpful when there is a loss of central visual acuity and only peripheral vision is there. So with these field expansion prisms, we can see something with these field expansion prisms. And of course, telescopic contact lenses. Sometimes the handheld devices, they are not acceptable to the patients. So with the telescopic contact lenses, when we place that contact lenses into the eye, the person can see to some extent for near as well as the intermediate distance. So these are the optical devices which are routinely in use for various low vision aid management. And these are the non-optical devices. Non-optical devices are basically assistive devices. So with the help of these devices, a person can count currency notes, a person can judge what is the image what is the object which is placed on a table or which is in front of that person. So most commonly used, these are the magnifiers with illuminated light. These type of bars, or these type of table like structure where one can place any object and accordingly judge. And this is the currency counter for this can be used even by the blind persons. And these devices, they are little bit helpful when there is a glare or when there is a low visual acuity in the bright light. And of course, these days, mobile phones are helpful to some extent in low vision aid clinics. These are the assistive devices. Assistive devices, although they are little bit costlier, but these are very much helpful in low vision aid clinics. So this is our low vision aid clinic. So we have two peripheral low vision aid clinics and one central clinic where all the devices are kept. And in our peripheral clinics, we screen the children, we screen the persons with low vision, and after that person is referred to our medical college. We prescribe accurate devices to them. Now, what are the challenges in the government hospitals? So these low vision devices, they are not everywhere available. This is the most common challenge. Even we are purchasing these devices from Calcutta, which there are so many persons who are manufacturing these devices in Calcutta, or there are one or two suppliers in Delhi also. No supplier is there in Punjab. And none or less availability of assistive devices. And of course, the most important is training. Training is not available in everywhere. It is, there are few centers in India where the training of the low vision devices is available. And of course, inadequate funding. So funding is now these days it is not the problem in government sector. Government is funding so much for low vision aid clinics and non-acceptance to devices. This is also very common because these are the higher magnifiers. So in initial period, patients complain of headaches, eye aches, like that. And, and of course, as these devices are bigger in size and the patient has to carry all the time these devices with him or her. So there is a non-acceptance to devices also. And of course, social stigma associated with the visual disability. And of course, transportation issues. Sometimes the assisted devices, they can only be kept at home. So those devices cannot be transported to the other places. So these are the challenges in the government hospital. But I am telling you that the government is doing a lot for these low vision aid services these days. And although these services are available at a few places, but we receive various patients from the periphery for a prescription of these glasses. And another part is rehabilitation, which is very important. Rehabilitation part is very important. So there are different there are different programs by Ministry of Health, Government of India. So where UDID card is formed of the disabled persons and the disability certification is there. Then there are special schools in every city for these type of low vision persons. There are different government schemes and concessions for the low vision aid persons. So rehabilitation is also very important. So thank you very much for your patience hearing. This is the in brief what we are doing in the government sector for implementation of these low vision aid services. Thank you.
Thanks, Professor Kamaljeet, for your pioneering work. But I would love to hear a bit of statistics from your institution. And it will be excellent if after 1 month in Palampur, if you just put some statistics year-wise, how many patients you are tackling and what are the common types of eye diseases amongst them, congenital or retinal, whether acquired or other, and what type of devices are you prescribing them. But the most important is the compliance. How many of them are using those devices and how many of them have procured at free of cost from your institution as well as from outside. So all these data can give a beautiful outlook of your extraordinary service which you are carrying out for the last 10 years or more. And in that way, we will be benefited to implement it in other parts of the country. Now we have another good speaker from Dr. Vikas Gupta of Haryana, though it is not on LVA, but he will talk on some other topics. Dr. Vikas, please do come and have your presentation, please. As we have got enough of time, we can have the talk from Dr. Vikas Gupta.
Thank you, Dr. Samantha, sir. I would like to thank AIOS and Punjab Ophthalmologists Society for giving me this opportunity. Although this talk was not listed in this session, but sir asked me to present this. I prepared this talk for some PG students. So I will be talking with you on causes of acute red eye. Acute red eye is a frequent cause of presentation to eye clinics and general OPD clinics. It is a sign of ocular inflammation. It is generally seen in self-limiting conditions like ocular allergies, conjunctivitis, etc. But it could be a sign of potentially sight or life-threatening conditions such as orbital cellulitis, acute angle closure glaucoma, keratitis, scleritis, uveitis, uveal tumor, and endophthalmitis. So there are some red flags of acute red eye. We should, when we everybody when examine a patient or encounter a patient in OPD with acute red eye, so these signs you should look for always. Keep in mind: reduced visual acuity, photophobia, moderate to severe pain. If the patient is having headache and nausea, elevated IOP, corneal epithelial defects, corneal infiltrates, anterior chamber inflammation, there is evidence of foreign body or penetrating trauma to the eye, and there is anisocoria, then different size of both the pupils, then shallow anterior chamber, or if there is proptosis with painful extraocular muscles. Then we categorize the causes of acute red eye depending on the structure involved. Basically, etiology: lids, blepharitis, marginal keratitis, trichiasis, chalazion, striae, subtarsal foreign body, canaliculitis, or dry eye syndrome. And conjunctiva part, it could be conjunctivitis, which could be many types like bacterial, viral, allergic, subconjunctival hemorrhage, pingula, pterygium. Then coming to cornea, there could be various keratitis like bacterial, herpetic, fungal, acanthamoeba keratitis, foreign body on the cornea, abrasions on the cornea, or chemical injuries. Then in anterior chamber part, there could be anterior uveitis or acute angle closure glaucoma. Other disorders like herpes zoster ophthalmicus, episcleritis, scleritis, orbital cellulitis, preseptal cellulitis, dacroadenitis, and dacrocystitis, they all present with acute red eye. Now in the clinical evaluation, you should visual acuity should be noted in every patient. Then in the eyelids, you look for edema, erythema, telangiectasia on the lid margins, discharge, presence of scales and crusts, vesicles. Look for legophthalmos and proptosis. Always evert upper eyelid to check for foreign body beneath the eyelid. Conjunctiva part, you should look for congestion, whether the congestion is diffuse or circumcorneal, chemosis, presence of follicles, papillae, discharge in the fornices, any nodules, conjunctival tear. In the cornea, look for any epithelial defects, dendrites, erosions, subepithelial infiltrates, corneal edema, DM folds, foreign body inside the cornea, any infiltrate or abscess in the cornea, stromal haze, keratic precipitates, corneal abrasions or corneal tear, and there could be sensation loss. Globe tenderness should be checked by gentle digital pressure, but it should be always be avoided if penetrating injury suspected. In the pupils, always look for size, shape, and reaction to light, presence of RAPD, relative afferent pupillary defect. Then anterior chamber, you look for cells, flare, synechiae, hyphema, and hypopyon. Eye movement should always be checked because in orbital cellulitis and preseptal cellulitis, they will be restricted. They will be restricted in orbital cellulitis and they will be normal in preseptal cellulitis. Lymphadenopathy, always look for tender palpate for periauricular lymph nodes. You usually seen in viral conjunctivitis. Then complete fundus examination is mandatory in every case. So, if we, I'm just skipping the part. I'm going to discuss viral keratitis. I think this is a very lengthy slides. So just herpetic keratitis. Herpetic keratitis is the most frequent cause of corneal blindness in the United States. Most common cause of infectious blindness in the Western world. Approximately 2 million people worldwide have impaired vision from herpetic eye disease. Pathophysiology, there is primary infection which usually occurs most commonly in the mucocutaneous or ocular distribution of the trigeminal nerve and can present as a non-specific upper respiratory infection. Then virus spreads from infected epithelial cells to the cell body in trigeminal ganglion where virus persists indefinitely and in a latent state. Then reactivation of herpes virus can occur any time in the body in the lifetime, and there is interneuronal spread of HSV within the ganglion cells which allows patients to develop subsequent ocular disease without even having primary ocular HSV infection. So primary ocular herpes usually occurs in childhood, uncommon during first 6 months of life. Mostly infection is subclinical or cause mild fever, malaise or upper respiratory tract infection. Ocular manifestations are generally acute follicular conjunctivitis, keratoconjunctivitis, or periauricular and eyelid skin lesions. Earliest involvement is diffuse punctate keratopathy. These lesions are mild and self-limiting. Then we have various types of herpes simplex virus keratitis like epithelial, stromal, endothelial depending on the layer of the cornea involved. Epithelial involvement, the most common presentation is, the earliest presentation is corneal epithelial vesicles, and most common presentation is dendritic ulcer. Dendrites are the branching linear lesions with terminal bulbs, and there could be other associated features like reduced corneal sensation, mild subepithelial haze, and follicular conjunctivitis. Then dendritic lesions, they coalesce to form geographical ulcers if we give steroids to the patient and patient is misdiagnosed as some other infection. Then in the stromal part, there could be necrotizing or non-necrotizing stromal keratitis. In necrotizing stromal keratitis, there occurs active viral replication within the stroma, which is generally immune-mediated. So it is characterized by epithelial defect, stromal necrosis and melting. There is dense stromal infiltrate and associated anterior uveitis with capes underlying the area of active stromal infiltration. So it leads to, it is very aggressive kind of melting occurs, corneal thinning and perforation occurs. There is a lot of scarring in the cornea, vascularization and lipid deposition occurs in later stages. So it should be aggressively treated with antivirals and topical antibiotics and cycloplegics. And conjunctival flap and cyanoacrylate glue in cases of perforation should be attempted. Then immune stromal keratitis. Viral antigen in stroma triggers intrastromal inflammation. In this case, the overlying epithelium is usually intact. So it is characterized by stromal edema, vessel immune rings, stromal neovascularization, and lipid keratopathy. Again, the complications are disciform keratitis and scarring of the cornea. So again, aggressively treated topical steroids and topical antivirals. Oral steroids are given in severe cases. Endothelitis. The pathogenesis is unknown, may be immunologic. It is called as disciform endothelitis. There is a round cone-shaped zone of stromal edema, and on examination you see the capes behind the area involved. So basically the patient complains of blurred vision with halos around the light due to the corneal edema present. And later on, neurotrophic keratitis is the severe known infectious degenerative disease of corneal epithelium characterized by impaired healing. Absence of corneal sensitivity is the hallmark of NK, which ultimately leads to corneal stromal melting and perforation. There are lot of causes of corneal hyposthesia: herpes keratitis, leprosy, congenital, familial dysautonomia, golden hair, Gorlin syndrome, Mobius syndrome, topical medication abuse, then anesthetic abuse. Most common is cocaine abuse. Then we use lot of topical drops like timolol, betaxolol. They all cause diclofenac sodium. They all cause corneal hyposthesia. So various types of corneal dystrophies, regular long-term contact lens wearers. Then there are some corneal incisions, surgeries, chemical burns, and trauma to ciliary nerves during vitrectomy and photocoagulation. Increasing age, diabetes, vitamin A deficiency, and drugs like narcoleptics and antipsychotics. They all cause reduction in corneal sensitivity. Then again, fifth nerve palsy due to neurosurgical procedures limiting fifth cranial nerve. There could be neoplasms. Acoustic neuroma is the most common. Then aneurysms, facial trauma, multiple sclerosis, stroke, and congenital hypoplasia of the trigeminal nerve. Again, I will just emphasize on in the management part of neurotrophic keratitis, we should emphasize on the prevention of epithelial defects because of profoundly impaired healing of the epithelium. Depends on the epithelial condition at initial presentation and the degree of corneal hyposthesia. An epithelial defect in the setting of corneal anesthesia is a serious ocular condition requiring prompt and aggressive therapy to prevent ulceration and possible perforation. There are various treatment options being tried in neurotrophic keratitis like preservative-free artificial teardrops, therapeutic soft contact lenses, topical autologous serum application, amniotic membrane grafting, conjunctival flap, lateral tarsorrhaphy or botulinum-induced ptosis, topical nerve growth factor application, silicone punctal plugs, antibiotic eye drops, cyanoacrylate glue, and DALK or penetrating keratoplasty if there is perforation and perforation of the cornea. If you allow me, I can just discuss with you acanthamoeba keratitis also. It is caused by free-living organisms known as acanthamoeba, commonly found in water, dust, and soil. They prey on other microbes. They exist in two forms. More vulnerable form is the freely mobile trophozoite form. Characteristic double-walled cyst, extremely resistant to extremes of temperature, desiccation, irradiation, antimicrobial agents, and other changes in environment. So, basically, risk factors are most common is contact lens wear, seen in more than 90% cases of acanthamoeba keratitis, responsible for more than 90% cases of. Then trauma, swimming while wearing contact lenses, non-compliance with CL contact lens disinfection systems, and water contamination and warmer climates. Then minor risk factors like steroid use, topical anesthetic use, and use of cosmetics. One of the specific and important symptoms of acanthamoeba keratitis is the severity of pain in the early stages of infection. That is because of radial keratoneritis, epithelial erosions, and pseudodendrites. There could be severe anterior and posterior scleritis. Stromal infiltrates are normally seen, and limbitis is typically seen in acanthamoeba keratitis. Anterior uveitis that leads to transient hypopyon. Medical management, biguanides are the first line of treatment. That is polyhexamethylene biguanide and chlorhexidine. Then other drugs used are diamidines, propamidine, hexamidine, neomycin, only effective with additional drug to polyhexamethylbiguanides. Then antifungal agents, voriconazole and posaconazole are effective against the cystic phase only. Then miltefosine, highly effective, but it is very expensive. And NSAIDs are used when there is severe corneal inflammation, limbitis or scleritis. In cases of acanthamoeba, generally surgical treatment is required when there is extensive epithelial involvement. You just remove the epithelium debridement and you remove the most of the organisms, and it is very effective if performed early when the disease is intraepithelial. Then in later stages, penetrating retoplasty is the only option when there is therapy-resistant infection, severe stromal melting with tracer perforation, and fulminant corneal abscesses are there. Keratoplasty in case of acanthamoeba keratitis has generally poor results due to relatively large grafts with higher risk of rejection and recurrence of disease in the graft due to the residual viable cyst. So I just want to highlight these slides, but the main part is whenever you see a patient, normally it is a routine presentation, acute red eye. So we should always, it is a common presentation of patients coming to clinics, ophthalmology clinics, and it is majority are caused by acute and benign conditions which are self-limited and not serious to vision or life of patients. But every patient presenting with acute red eye should be carefully examined for the treatment of the problems which can be life-threatening also, like orbital cellulitis, penetrating ocular trauma, keratitis, sight-threatening problems, scleritis, uveitis, and acute angle closed glaucoma. Thank you so much for your patient listening.
Thank you, Dr. Vikas Gupta, for your talk out of our scheduled theme of discussion in AIOCMTC session, low vision aid. So the time is over. We would like to close the AIOCMTC session, and I would like to request the convener of the next session to take the mic. Once again, I'd like to convey our invitation to each one of you to AIOCM Palampur 2025, the annual conference of Association of Community Ophthalmologists of India at Rotary Eye Hospital Palampur on 31st October, 1st and 2nd November. The registration fee is very low, only 2,500 rupees for the postgraduate students, and there are 100 prizes for postgraduate students in different academic conditions. The first 30 registrants or postgraduates will be given free accommodation at Rotary Eye Hospital Palampur. So with this, thank you very much for your kind attention. Please please register at the earliest for Aqua and Palampu 2025.